Good morning, everybody. For those of you who don't know me, I'm Andrew Bowen. I'm a fourth-year medical student here. And thank you guys all for coming today. I just want to, before we start, the majority of you guys have class at 8, right? Okay, so what I'm thinking we're going to do, because I think you guys are going to want to ask questions, is I have some questions that were sent to me. I've kind of used that to come up with some overall arcing themes we were going to talk about. I think we'll breeze through some of those so that we can give you guys some time to ask questions. Does that sound good? All right, so just a little beforehand. We envisioned this Dean's Chat. It was actually a group of us about a year and a half ago. There was the thought about it, as you guys have probably already know, the Cleveland Clinic is considered one of the best run healthcare systems in the country. And for that reason, we're only 3 floors above below the executive team that makes the decisions that are the reason why this place is the way it is. And so we thought that would be a prime opportunity to learn from them. So luckily, Dr. Young was very fortunate enough to listen to us and go ahead and start this last year. So he unfortunately couldn't be here today, but we have Dr. Franco who's here. Today we have Dr. Kelly Hancock, who is the Executive Chief Nursing Officer of the Cleveland Clinic Health System. She's also the Chief Nursing Officer for the main campus. So she's been here for 25 years. Before that, she was actually the nursing director for the critical care unit here, as well as the Heart and Vascular Institute. And as you guys will see, those who haven't started their 3rd year yet, if you're a nurse on that floor, you're working hard. Those are the hardest patients to take care of. And she was in charge of all of that. She's actually a native from Ursuline College, which is in Pepper Pike. That's where she got her master's in nursing. And she has a nursing executive board credentials, as well as just recently, Dr. Hancock, you completed doctorate in nursing practice.
I did.
Congratulations.
Thank you.
She's received multiple awards. She was actually a distinguished alumni for her school in 2013, Ursuline College. Is pretty neat. And also received the Maria and Sam Miller Nurse of the Year Award for the Cleveland Clinic. But that's just a few of the awards she has. So we'll go ahead and get started today. And we're first going to talk about how she got to where she was. So, Dr. Hancock, can you tell us how you decided to pursue a career in nursing?
Sure. So first of all, I just want to say thank you both, and thank you to Dr. Franco and Dr. Young for allowing me to share a little bit of my own experience in the profession of nursing and how we work with our physician colleagues. It's really a pleasure to be here, so I look forward to having great conversation with all of you, so thank you. And I also want to thank you for all the preparation that you put in place, because I know how hard you worked in getting this assembled well, so thank you for that. So getting back to your question about my interest in nursing really stems back to my father had a chronic illness. And, you hear this story often and how you get into healthcare. And I was one of 4 children, and my father, who is now deceased, was older and had children late in life. And so I was kind of the one who kind of was by his side all those years. And so he often reflected, you would make a great nurse. And to be honest, I wanted to be a dentist. And so I'm so happy I chose the path of nursing for all the variety of reasons. And interesting enough, he passed of heart failure. And funny how my career took me to the Cleveland Clinic, and really my clinical career started in heart and vascular, really the heart center before we had institutes here at the clinic. So I had a wonderful opportunity. I always think things happen for a reason, right? And so I think it was very serendipitous, if you will. And so I wouldn't have changed my decision. Just like you, I think you have a calling to go into healthcare. And for me, nursing, clearly is a noble profession. Just as medicine, I think, we have such an opportunity where we see patients across the whole continuum of care. And for me, that was something that I felt I could really influence and really want to help take it to another level. So we usher people into this world, but we also usher them out with dignity. And so what an awesome responsibility that is. And I wouldn't have changed anything in my career for that.
Can you tell us about your time at Ursuline?
Sure. Oh, God, it was great. So I chose Ursuline because obviously they had a very great nursing program. And, I am one who does well in smaller settings, and Ursuline is a private college that has a smaller class size, very interactive, very hands-on, didactic. Clearly, I believe in the holistic approach to education, and so they were able to provide that. So not only looking at the science and the evidence of nursing and in healthcare, but really looking at the holistic needs of the patient. So I felt that that curriculum provided that education for me, not only at the bachelor's level, because that's where I got my bachelor's, and then when I went back for my master's as well. So it is a great college, and clearly always be fond in my heart.
So when did you, was it when you were a student there that you actually were at the clinic?
It was. So when I was in nursing school there, is just as all of you do your different clinical rotations in town. So I had a variety of opportunities to do some rotations at University Hospital, at the time a hospital called Mount Sinai, of course the Cleveland Clinic, St. Luke's, which isn't open anymore. So there's a variety of different hospitals. So when I had my exposure here in my clinicals, it was on a basic medical floor. And at that time, I thought, oh my God, the big Cleveland Clinic, and it wasn't even as many buildings or as big as we are today, or really even a health system. Okay. Our first family health center was back in '93. Well, your husband.
Maybe even 95.
95. So it was before all of that, but to me and everybody else, it was like, oh my gosh, you're going downtown to the Cleveland Clinic. So when I was here, I think what I loved about it as a student was the energy. To be honest with you, the pursuit of trying to find a way to provide better care for patients. I was really drawn to the teamwork, the energy. I just thought it was awesome. So it so happened that they had this, the following year, a summer internship for nursing students. And I remember that they said it was very selective, and you had to be going into your last year, and you could do a summer internship here, no benefits or anything like that, but just really to get that experience. And the idea was that you could work along a registered nurse and do basically all that he or she could do in legal limits without your licensure. So I thought, what a great opportunity for me. So I went ahead and pursued that application. Fortunately, was able to get it. And it just so happened that it was in the cardiothoracic area where I did that internship. And so clearly loved it. I learned so much. I think it's prepared me so well going into my final year of nursing school, gave me the confidence that I needed, not only from a clinical standpoint, but as I reflect back, I think it gave me the confidence on how to interact with a patient and their family, because oftentimes you go in there and, as I mentioned earlier, what an awesome responsibility. I mean, you have these people's lives in your hands. So they look at you, whether you're a student, or, a professional at this point, ready to take care of these patients. And sometimes it's a bit overwhelming, and sometimes you don't have that confidence. So for me, it gave me an opportunity to really have that experience, and I thought that was so valuable. So when I was at Ursuline and here then, afterward the internship was over, I stayed on to work part-time as a nursing assistant while I was finishing nursing school. And I stayed in the cardiothoracic area, which I loved. And then subsequently after that, once I graduated, applied for a position here as a registered nurse. Took care of post-open heart patients, heart transplants, patients waiting for a transplant. I took care of one of the first LVADs, and you guys obviously know what an LVAD is. So at that time, it was like the size of a refrigerator, and I remember how overwhelmed I was, and to be honest with you, frightened, because they said, whatever you do, it can't stop, and if the plug comes out, you have to manually pump, and I'll never forget that. And so, I had other patients, but I just remember being just so focused on this particular patient, and I wish I had the picture to share with you, but there is a picture of me with the very first, one of the very first patients, and I had very long, curly, 90s hair, blue eyeshadow, early 90s. And, I'll never forget him or his little daughter at the time. So I often reflect when I look at that picture, my gosh, how old she must be now, and I wonder what had happened to him, because he was, not from the state of Ohio, so I don't really knew what happened to him. But again, I was just drawn to this environment. And, at that time, I was probably soon thereafter, particularly in heart, if from the U.S. News and World Ranking standpoint, we were notified that we were #1, because as you know, this year we just celebrated our 22nd year being the #1 heart care in the country. And so I don't think I really realized what I was becoming part of at that time. And so it's really just grown to be a tremendous organization, both in heart but across all of our specialties, that really provide the best care to our patients. So it was just really fun to be part of that from the very beginning.
How would you say it's changed over time? Seeing
Oh, my
it at
goodness.
the beginning?
I think it's changed so much. I think from a nursing, from an organizational standpoint, you know, as I mentioned earlier on, we were in departments, you know, so we had the Department of Medicine, we had Department of Pediatrics, Heart, and, you know, as watching Dr. Cosgrove, you know, in his journey, you know, so I had the opportunity to work with him and take care of his patients, because obviously you should know he's a cardiothoracic surgeon, so I had that opportunity to see him there. And then he was chair of cardiothoracic surgery, thoracic surgery, had an opportunity there. And then obviously when he assumed the leadership position here, so I've seen an opportunity for that to grow. So getting back to the department piece, you know, Toby had an idea at the time is to really provide better care for our patients in the form of institutes and clinical institutes, which I'm sure you're all very aware of. And so as you look at that model alone evolve, it's been incredible. Really having focused colleagues come together with the idea of having, you know, clearly our physician, our advanced practice providers, our nursing colleagues, our other disciplines, all coming together around a specialty to provide that best care for our patients. That's evidence-based or expert opinion, but knowing that we're all together focusing on that patient, those centers of excellence. So for me, not that we weren't doing that by means in the department, but I think it just gave us a more focused approach to providing the best care that we can for our patients.
So what was before? There wasn't institutes?
There was not institutes, there were departments. So for example, you had the Department of Surgery, so all of the surgery specialties went up to that department surgery. There was a department surgery head, Department of Medicine, and underneath that was cardiology. It was a variety of different service lines.
For a while, there were divisions.
Yes. So yes, there was a variety of different models. But for the past 11 years, Toby's been in the role 12, I believe. Really, we've been under this institute model. And when you look across the country, it's interesting to watch how other organizations have centered their care around this kind of a model. And I think clearly we are the leaders. People look to us as an organization to kind of lead as we do. And as you mentioned, it's pretty exciting. Had the opportunity to see so many different people come here really just for using us as an example on healthcare, whether it's our group practice model for our physician colleagues and how we focus on care. We're not incentivized to provide that care. It's really on getting back to the mission and vision of the organization. And it's really neat to be part of an organization that everybody in the country, everybody in the world is looking at internationally. It's really been a fun journey.
Yeah.
And then looking at, you know, now when you look at our international reach is just tremendous. So prior to our international growth, clearly we had our physician colleagues were sought out to go internationally and take care of a variety of different patients. And we were really one of the major hubs, and still are, you know, before 9/11, we would be inundated with international patients all the time who are coming here to seek our health care. And, you know, obviously with 9/11 came a little bit of changes, and that kind of slowed a bit. But, you know, with Cleveland Clinic Abu Dhabi now, you know, Toronto and all of the other things that we're doing, looking at London, I mean, I think it's just really spreading our expertise out from an international standpoint, which is really incredible to be a part of, that you have that much of an outreach on patients and the impact on their lives.
Right. And actually getting onto that, now coming to your current position now, how would, you know, we know you're the Executive Chief Nursing Officer, but can you describe what
Sure.
you do in that role?
Sure. So when Dr. Cosgrove had the idea of forming the clinical institutes, a couple years after that, he says, you know, I really would like nursing to come together under an institute. I really want it to be integrated, standardized, so we can provide the best care for our patients and have an overall governance. So prior to the Nursing Institute coming together, there were chief nursing officers at each location, which is true today, as well as this location. And occasionally they would meet, they would share some best practices. But you can imagine we had so many nurses who were part of our health system. They were compensated differently, they had different job codes, we had different standards of practice. Again, nothing wrong, anybody was doing a wrong thing, it was just that you were functioning in silos. So when Toby had the idea of bringing us all together, we did have a executive chief nursing officer. That's where the idea came of. And really the idea is to really standardize and integrate, provide a common mission and vision, connect it with the overall organization. So my role, so we have about 20,000 nursing caregivers across the Cleveland Clinic Health System. So when you look at our overall number of caregivers that we have about 49,000 caregivers in the Cleveland Clinic Health System, 20,000 of which are nursing. So we have about 15,000 registered nurses. We have about 4,000 support caregivers, like our aides, our techs, our MAs, variety of different leaders. And in addition to that, we have about 1,400 advanced practice providers, most of which are advanced practice nurses. We have our physician assistant colleagues as well. So we're a large group, and so kind of bringing everybody together has been a tremendous opportunity. So we're in our 9th year as an institute, and we've done so many things. So from simple things, but yet important, equalizing compensation, providing standardization of practice and protocols, onboarding, taking a step back in our old model. Each institution had their own way, their own educators, the way they brought people in. And really in the spirit of one Cleveland Clinic and acting as a unit, we've all come together, really with the sole purpose for our patients that if you're a patient coming into any one of our facilities, our family health centers, any one of our hospitals, you can and should expect the same level of care, professionalism, and competence of any Cleveland Clinic nurse. And for us coming together, I oversee a variety of talented leaders and caregivers who make it happen every day. So I often get asked, my gosh, that's such a large scope, but I am so fortunate to have such a talented team. One of your greatest assets as a leader is who you surround yourself with. And so I have really done, hopefully, a good job in selecting a diverse group of talented individuals who have come together to really help me lead this tremendous institute, along with our great physician colleagues as well. So it's really been a great partnership. So a lot of day-to-day, oh goodness, so I would bore you in some of these things. Some of these things you'd say you're making it up. But I mean, from personnel issues to regulatory to quality care to onboarding, making decisions. In our current healthcare environment, looking to see how we can still provide that quality care that's accessible and affordable to our patients, and not making those decisions alone, clearly making it with a group of disciplines and colleagues from across the system. So there's a variety of different things. The good news is in this organization, as I reflect back, I think the strength in nursing and the partnership has really grown with our physician colleagues. And so being part of those decisions has really been incredible to have that voice for nursing.
So I've actually put up on the screen all the different nursing officers, which I believe
Yeah.
they report to you.
They do.
So my question for you is how do you keep in contact with people like that? Do you guys have meetings? Do you see
We
them
do.
in person?
Oh, yeah. So twice a month for 8 hours, every other Friday, the CNOs and the ACNOs and I come together, and we have an operational meeting where we have decisions that need to be made, and then we have the other meeting is more of an informative. So there's a lot of colleagues who want to come and have the audience of the chief nursing officers and leaders to help make some decisions and give different information. So that meeting we've set aside for people to come. So our pharmacy colleagues, some of our physician colleagues, anything that's going on in the organization, from protective services, outside folks who want to come in. And so we meet from that as a group. On an annual basis, we have a strategy session where we bring, the group together and we look at our accomplishments from the prior year. We try to focus on what we still need to focus on now and moving forward, and how does it align, most importantly, with the overall strategy of the organization. And that's so important. And then at that time, we also have a discussion on, most importantly, how do we connect these 20,000 people to that strategy and to that mission? How do we communicate? Because you can imagine trying to bring all those folks together, and how do you communicate, and using different modes of communication is somewhat challenging, and so we try to be creative in that. So we have a lot of discussion during that strategy session. Separate from those two meetings, I have monthly meetings with the CNOs. One month they'll come here, to the office, and then I go to the hospital and kind of turn it into a rounding experience. So for example, yesterday, I was out at Ashtabula County Medical Center, which is about an hour or so from this campus. And it's one of our affiliates, and so I had a great opportunity, to round on all the nursing units. I had lunch with the frontline leaders, and then had some time with the chief nursing officer there. So, that often happens. I also make it a point to meet with our family health centers too, because they play such a vital role in the care that we deliver across the care continuum. And to be honest with you, sometimes they're like, what about me? Perhaps I'm not part of a hospital, but I provide such valuable care. And so we often make it a point, or I do, is to go out to the different family health centers, out to the one out in Worcester, which is about an hour or so away too, to the ones that are local here, and just really hear what's on their minds, share with them some updates, what's going on. So a variety of different things, but we stay in contact. Sometimes there's not enough hours in the day.
Yeah, it seems like a lot. And you had mentioned also Abu Dhabi. What was your role in that, in establishing
Sure.
your nursing care?
So we had the opportunity to, from the very beginning, help decide what that model should look like.
Yeah.
And really taking some time to really understand the requirements from a regulatory standpoint, the education, and what exams and certifications were needed for nursing staff to practice there. And so we worked with a lot of international recruitment agencies to see what we could do to recruit nurses there. We were fortunate enough, we held many sessions here at this organization, and we had a good handful of nurses who wanted to work over there, both in a leadership position and at the front line. It was interesting. So it was either nurses really at the beginning of their career thought this would be an awesome opportunity, or those who were really saying, you know what, this would be a great last hurrah at the end of my career. My kids are grown, my husband and I, we can go do something. So it's really been a good opportunity across the spectrum. And for us, it was a way to bring some novice folks in, as well as some experience to help mentor, and look across the board and how we can continue to build that nursing workforce. From a chief nursing officer standpoint, we're on our second one for Cleveland Clinic Abu Dhabi. So we had the fortunate opportunity of having a gentleman who had international experience, was from the U.S., but he had led different organizations in Saudi and so forth. So he was just really pivotal in helping us from a strategy standpoint. And so, he came to me and he said, this has been about 3.5 years. My wife, who's in Iowa, who's already retired, is like pulling on me like, come on back. I said, no problem, we're not going to make you stay. And so then we worked to see who we could get to go over there. Now, clearly, ideally, I would have loved somebody from our organization to do that, but at the time, both personally and professionally, it just wasn't something that was doable. With that said, we also had an opportunity to recruit a very high-value leader from the University of Iowa, and she worked in California and so forth. And her name is Ann Williamson, Dr. Ann Williamson, and she's just been a tremendous leader out there, and it's really been fun to watch them grow. It's been fun to watch them collaborate. If you ever have the opportunity, I don't know if anybody's had the opportunity to visit, it's an incredible healthcare system, very interesting. I think it's once in a lifetime opportunity. It's been fun. Yeah.
So going and moving, you started this position in 2012, and a year after that, Cleveland Clinic main campus, Hillcrest, and Fairview all received magnet recognition.
Right.
And so for Hillcrest, that was the first time.
It was the very first time for Hillcrest. So magnet recognition or designation is a distinction that's given into an institution that recognizes excellence in nursing, and it also recognizes and the organization supports that from a culture standpoint. I have to tell you, I think that process is harder than any of our regulatory bodies. You know, you would imagine, thank God it's electronic now, but when this campus went for its initial designation, this is going back to 2000. So we're going on our fourth one because it's every 4 years.
Yeah.
But the booklet was well over like 1,500 pages, and I'm talking pages. So you think about dissertation, I think that mine was nothing compared to what this was. Thank goodness it's electronic now. But there are certain levels of evidence that you have to produce from a quality standpoint, from a financial. You have to show evidence in how frontline caregivers are empowered to make decisions, particularly as it relates to the nursing. They have an opportunity to interview many of our physicians while they're here. So we have to submit different information. They have to come for a site visit, and it's about a week with a number of individuals, and it's pretty intense. But the one thing, or there's many, but the really one thing that stands out for me during those visits is to watch people just shine. And really just to see the smile on their faces as I'm watching you all really speak about their work and the passion that they have for their work, and most importantly, our patients. It is really an awesome time for me to sit back because they don't want to hear from me. They want to hear from those that we serve as well as our physician colleagues. And it is so fun for me to watch that because it really brings it all, it fills my heart. It brings it all together for me. So we are so happy that Hillcrest also, because you know they've worked incredibly hard, and just, hopefully you're familiar with Hillcrest Hospital. Very busy organization as well, high acuity as well. And they really do a great job, and so they deserve that recognition. So we're really excited when they got that designation.
Yeah, and if you guys haven't been to Hillcrest or know where Hillcrest is, you will when you are. Most of you will know on your labor and delivery rotation.
Oh yeah.
So
Oh yeah.
it's where any babies from the east side, they're part of the Cleveland Clinic Health System. They come from there. So that or Fairview. So. What things did you do to ensure that? Because that was the first time, and it's not an easy process.
Sure. So it was really lessons learned. So again, going back to the beauty of coming together as an institute, you know, so obviously we went here first and then Fairview, so really taking lessons learned about what the surveyors wanted and what they didn't want. Instead of recreating the wheel and hiring other resources, really just deployed resources over there to help with some of that. And, you know, making sure that that environment was supportive of a culture that allowed our frontline nursing caregivers to provide that care that they want to, and that is really supported in the Magnet model. Magnet is very important for a variety of reasons. You know, it validates the work that's being done. It really, for our patients and the families, you'll be surprised how much our patients and families do their homework now. They want to know a variety of different things. They're very savvy on the internet. They look, they know, they're very knowledgeable. So it's funny when some will ask about that. Equally important is, you know, how do we attract caregivers here? Because we want the best and brightest, just like all of you. And so when we have like new graduates, because we're really a magnet for new graduates, everybody wants to come to the work at the Cleveland Clinic. One of the first questions they asked clearly was, we know you're a magnet institution, what are you doing to continue that journey? And the second question they asked is, do you have a nurse residency program, which we do, and we speak about that as well. So it's interesting, compensation's not top of mind, which is good, because you know then we know we're getting our best of the best, but it's really those important elements of attracting caregivers. So Sue Collier is our Dr. Collier is our chief nursing officer at Hillcrest Hospital. And when Magnet was here, and during the ceremony, the big ceremony, they invite, you know, city officials, board trustees, obviously hospital leadership, and most importantly, as many staff as can come. They called out Dr. Collier as really providing exemplary leadership from a nursing standpoint at Hillcrest Hospital, which is really just something extraordinary in my opinion.
Right. And so go ahead and just trying to,
Sure.
without some time for questions, I'm going to go ahead and go to the Accountable Care Organization part of our talk. I think it was just last year we were designated.
That's right.
What does that mean for the clinic?
So are any of you familiar what an ACO is? No? Yes? No? I think simply put, it's really having a group of providers come together, really having, with Medicare, for ours as Medicare patients, a shared savings program. So really looking at populations of patients who are at risk and making sure that you can provide a provider group that really looks at them across the whole care continuum, and that you would get some savings. You know, you have some skin in the game, because if you don't provide these certain outcomes, then you get a penalty or you don't get reimbursed. So we began that journey, as you mentioned, last year, and it's been incredible as it's evolved. So it's not only including Cleveland Clinic providers, but it's also some of our providers in what we call Quality Alliance, which is a group of independent physicians who are not Cleveland Clinic physicians, but practice in our organization. So we've come together to make a commitment to groups of patients. And the role that nursing plays in that is really a vital role, because we really have to make sure that we identify those patients along with our providers, our physician colleagues, who are at risk. And obviously we want to provide them the best care that we can. We want to keep them out of the hospital, because nobody wants to be in a hospital. And we have to make sure that we measure those outcomes and we meet those needs. So whether it's from their glucose control to their hypertension, to how many times they were readmitted if they were heart failure patients, there's a variety of different elements that we're held accountable for. And so from a nursing standpoint, what we've really begin to examine and put in place are what we call care coordinators. And I don't know if you're familiar with that. Some of you are shaking your head. And so typically these are registered nurses. Some can be social workers, but typically they're registered nurses who work with populations of patients. So we'll use heart failure as an example. And they really manage their care across the care continuum. And so we've done a variety of different things to educate them, meaning providing special education for this group of individuals, to ongoing education, to others who are impacted, to education to these patients. And so if you have a patient, a heart failure patient who you saw in your clinic, and for whatever reason they came through the emergency room, they would contact the care coordinator who would say, you know, Mr. Smith is in here. I see that you just saw them, or the physician just saw them in the outpatient clinic. What are some things that you can tell me? So they have a conversation about really what we call a warm handoff, about certain elements as it relates to compliance of medication, adherence, and so forth, really looking at their whole plan of care. And the idea is, as opposed to admit those patients, what are some of the things that we can do to make sure that they get out of the hospital, and you as the care coordinator can call and check and have different touch points along the way to make sure that they're on their plan. And if they're not, what can we do to keep them on their plan? Mm-hmm. And so obviously the savings behind that, and I hate to quantify it as savings, but that's the reality of healthcare today, is that you're utilizing less resources to care for this very complex patient, but yet you're still providing that high quality of care, because you're not only keeping them out of the hospital, but you're measuring other outcomes for them. So this is very complex, our world, as it's changing in healthcare. And as I reflect back, again, this is my own perception over the years here, we've clearly seen a change. And it's not always doom and gloom. I try to look at it as an opportunity. It's an opportunity to be innovative, creative, look at different care delivery models, such as the ACO, that allow us to be viable in our community and in the healthcare organization overall. But it's not easy. And what I've watched, to be quite honest, apolitical here, whatever the Affordable Care Act, people think of it, what it has done is given people an opportunity to have care, and they haven't had care in years, right? So what we've seen in the particular past year and a half are really our doors in all of our hospitals and our clinics. People are just inundating our EDs, our clinics, all of our beds are full. And some of these patients, keep in mind, haven't had care in years. So now that they have an opportunity to provide or get care, they haven't had care in years, so they're coming to us very complex, very sick. And so it's a bit overwhelming, not only for those frontline caregivers who now have to look at a variety of different comorbidities, not they haven't had before, it's just been a bit different. And so these patients require a lot of resources, and we want to provide that care, but we have to do it in a more affordable approach. So when you look again at these patients that are at risk, and fall perhaps into the ACO, that makes sense for some of these individuals. Again, these are Medicare patients that I'm talking about, but it's definitely an opportunity. It'll be interesting to watch how it evolves over the years as well, in my opinion.
So for us as medical students, not having this or type of organization won't be a paradigm shift like as it has been for some. What role can we play?
Sure, that's a great question. I think as we look across all of our disciplines, I think the role that you all can play is really to be great teammates, and to be those partners, because Kathy and I were just speaking a moment ago before we started, we have to do it as a team. No longer can we do it in isolation in our own disciplines. And not that it was really acceptable before, but healthcare kind of drove you to that model, if you will, overall. And I think coming together as an interdisciplinary team, having that effective communication amongst one another, so whether you're dealing with your pharmacy colleagues, your nursing colleagues, whomever it is, having that open, effective communication is ultimately going to impact our patients and their families, because trust me, they know it. It's just so interesting to me. They know when we're not on the same page, and it obviously affects their outcomes. And so what I ask of you is that clearly have that open communication with all the disciplines that you work with, because that's where you're going to be able to have the impact, not only on the ACO, but all of these different elements that we're facing right now. As the organization, we do leadership rounds. I don't know if you're familiar with that. And we began this about 4 or 5 years ago. And really, at the time, our Chief Experience Officer, Dr. Jim Merlino, got the idea from UCLA. He was out there speaking about patient experience and engagement, and was looking at their leadership round. So he brought the idea here. Dr. Cosgrove said, I'll do it, but it can't be the flavor of the month. We have to stick to it, and we have to have measurable outcomes. So the idea is that we go out and we do it religiously once a month. Every hospital does it at the same time. All leaders come together, including Dr. Cosgrove. We go out in groups of 2 or 3 to different inpatient units, to different ambulatory clinics, with a couple purposes. Whatever the topic is at the time that we want to speak about as an organization, whether it relates to caregiver safety, patient safety, tools and resources, finances, whatever the case may be, or going to speak to the patients and families to see if we're meeting their needs. And so we went last month. I just brought up the role of effective communication, this example. And we were speaking to a patient who is very complicated transplant patient from out of state. He's been in and out of our organization a couple times for good reasons. But he had shared, obviously there was a disconnect amongst the entire team, to no one's fault, but there was not effective communication. And to look in his eyes and the eyes of his wife and really look at the holistic piece and how it impacted their day-to-day lives because of our ineffective communication as a team really just brought to mind the importance for me and others and how important it is that we're all on the same page. And that we are incredibly busy, everybody is, but to take a moment and pause and have that communication will go such a long way, not only for yourselves, but most importantly for our patients and the families. It was interesting, I left my card for him, we sat there for a while and came back. And that night I went to, one of my outlets is running. So I went for a run and I came back and I looked at my phone and I said, Charleston, West Virginia. Who called me from Charleston, West Virginia? Well, here was this patient calling from his cell phone in his room. And it was actually his wife, so I called back and they said, we are so sorry to disturb you. It was 9 o'clock at night. We just wanted to let you know that everybody's on the same page now and we really appreciate everybody's efforts. So again, it goes such a long way. That's one of many examples, and one of the reasons why we do leadership rounds, right?
Sure.
All right, thank you, Dr. Hancock.
No, sure.
So I think we have time, and around, I think, 7:55, we'll probably wrap up, but we have time for questions now. Is the mic going to stay there and people come up? Or? Yeah. Okay, so if you have a question, there's a mic right there. If you guys have, unless you guys want to speak up if you guys have a question. Anybody have a question?
Yes.
Go ahead.
I was wondering how you decided to transition from practicing into a more administrative role, and how that decision went and how
Sure. You know, it kind of happened by chance, to be honest with you. It was never, I don't think, a planned, early on it was never planned. It's an interesting story, you know, at the time, very early on, I was asked to like be charge of the unit and care for patients at the same time, but without a formal title. So I did it, and I seemed to like it, and they seemed to like it. You know, at the time it was leadership. And so one thing led to another, and as different positions opened, I've done a variety. I think I've done all the nursing leadership positions here, from charge nurse to assistant to nurse manager to, you know, I've done them all. And you get to a point where, you know, I often ask, don't you miss providing care to patients? And clearly that clinical, and that what brought me here, I miss that piece, but I know that I still provide care to patients in a different way. It's how I lead and how I help make decisions that provide that care to the patients that I want to provide. So I do deliver care, particularly not hands-on, but the way I lead and influence. Yes?
Given that there is the aging population going on, I was wondering what work is being done to kind of get ready for the future, like any initiative that's been happening, or what, like, changes in organization?
Sure. So I'm glad you asked that question. So when you look across our 20,000 nursing caregivers, there's some seasoned caregivers in our workforce, right? And so we're doing a lot of predictive modeling. So we're looking particularly on historical data on where caregivers have chosen to retire. So we're looking at different service lines that we think are at risk. So for example, when you look at some of our ORs, we have a number of nurses who, if they decide to retire, we lose a lot of that experience, that intellectual property, if you will. And so how do you replace that? And so we're doing a lot of things about building our bench. And so clearly we can't go up to somebody and say, hey, are you retiring this year? But we have an idea of where to dedicate more resources and internships and residencies programs, particularly in our OR setting. It's interesting. Many of our nursing programs here, Northeast Ohio and across the country, don't provide exposure to peri-op, believe it or not like they used to. So we decided to do our own thing. And so we are going to provide that experience for students. And we began that last year. It's been tremendous. We had turned some people away because you can only have so many students, whether it's nursing students, med students, other students in the OR setting. But we want to give those exposure to those areas that we need to bring some new talent in. So we're looking at that across the board. And that is a very good question because that's a concern for many across the country. Particularly as some of our nursing programs are not accepting as many students as they have in the past because they're limited on faculty. So it's a vicious cycle.
Thank you.
You're welcome. Yes?
How do you see the structure of the nursing units changing over the next 10 or 20 years?
Interesting. So I think within the next 10 years, let's take that for, I can only take like this year now. I think clearly you're going to see predominantly it's, you know, a team model. And so when you look here in Northeast Ohio, it used to be that you had a team approach on the unit, meaning you had a registered nurse, a licensed practical nurse, an LPN, and then perhaps a nursing assistant. You know, we've changed those terms over the years. In Northeast Ohio, at one time we had an abundance of LPN schools, programs, and those have really gone to the wayside. So we're very limited in having those level of caregivers and that expertise. So what we've done then is really tried to skill up to top of licensure or ancillary support caregivers. So here we call them patient care nursing assistants, PCNAs. Then in our ICUs and other procedural areas, we call them clinical techs or CTs. So we really have tried to have a focused effort on skilling them up so they can practice to the top of their licensure, because there are some things that they can do. You know, they can do some simple dressing changes. Some can draw, you know, blood, you know, with proper training and competency. Some can do sterile, you know, dressing changes as well. And some of those things that they can do really allows the registered nurse to really focus in on that patient and making sure that they focus in on what they need to. Not that that's not important, but that gives them more time. And I think as we look to the future, we're going to see more of that. Interesting enough, we really are trying to work with our veterans as well, and how do we re-engage them into the workforce. And so healthcare is a perfect opportunity. So we're working with different organizations locally and nationally to see how can we engage those individuals back into the workforce and perhaps help them with an education standpoint in healthcare. So just trying to look at different things across the board. We also have what we call as a Dean's Roundtable, and we just celebrated our 11th year where we meet with all of the deans of the programs and the colleges and universities for nursing on every quarter. And the idea originally was for us to give them feedback on the students they were producing, but it really has evolved to a great partnership where they give us feedback on what good partners or not at times we are for those students. And it's been fun to watch because we've been able to influence and by data some of their curriculum to really meet the needs of today's current healthcare environment. So I think as we continue those kind of partnerships, you'll see that evolution over the next 10 to 20 years.
Aaron's got a question over there.
Yes.
So I know you mentioned leadership rounds, but it's often hard in being in upper leadership to get the water to the end of the roast. So how do you do that on leadership rounds or otherwise, that you inspire people and show them without micromanaging?
Absolutely. So, you know, we kind of, not kind of, we believe in transformational leadership, you know, and the concept very simply stated behind that is creating a shared vision that you connect an individual with. So it's about establishing a relationship and creating that shared vision. So in our example, patients first in our organization is our guiding principle. I think everybody here connects to that. Everybody connects that they are a caregiver no matter what you do. Whether you work in housekeeping, finance, you are a caregiver because you influence that. But we, as an organization, have created that shared vision where people can connect with that. And so as an executive leader, I think it is so important not just to go on once-a-month leadership rounds, but to be visible. And I know others do that through a variety of different things, whether it's dinner meetings, town halls, just going out and about, having an open door policy. So there's a variety of different things that you do. You're right, it's hard not to be a micromanager, particularly when you have different regulatory requirements and there's different measurements that we have to meet as an organization. And in theory, obviously, it's the right thing to do for the patient. But, you know, we just had a leadership summit this year where we launched, you know, some of our new leadership behaviors as an organization that we want to align with. And one is, you know, demonstrating character and integrity. So I think that if you're a leader who has earned that respect, because respect is not freely given, it's earned, because you've demonstrated that character and integrity, I think the rest will follow and there'll be less micromanagement. And typically, to be honest with you, you know, those folks kind of stand out who need to be micromanaged. And that's something that, you know, we don't particularly like here at the organization, and we help them find a better seat at another table. Yes.
So I last year saw a presentation by an organization called Glide at UCSF that uses a nurse-managed care model, specifically to extend capacity for people covered, the populations covered by Medicare and Medicaid. And I'm wondering if you see the role of the nurse and the individual nurse in care evolving over the next decade or so, specifically with regards to that population?
Sure. So when, as I mentioned earlier, the care coordination model, not just have care coordinators for those patients at risk, but particularly in our primary care as well. So really that's what that model is reflective of, is having dedicated individuals to kind of be that one constant for that patient across their entire care continuum. So one of the roles that we put in place in nursing is an Associate Chief Nursing Officer of Care Coordination and Ambulatory Nursing, for a lack of a better term, because it's really not ambulatory nursing anymore because it's so much more involved, but that's what we have for right now. And her role is really to bring all of those care coordinators and individuals who work in that space together to provide that model of care for the patient, and that's how that's going to evolve. So not only does she oversee the care coordinators in our outpatient clinics, but she also oversees the care managers in our inpatient setting. And obviously the two have to connect, and so it's how do you provide that care across the continuum. We have nurse on call here, where a lot of our patients will call it a nurse on call, and they're part of that care continuum. And so we've brought them into the mix to connect along that model. And then lastly, we provide care in the home, right? And so we have what's called connected care here, which is really essentially our home care. And so it's just not nursing, it's pharmacies, a variety of different things. But we brought them into the mix. So when you look for a patient perspective across the entire care continuum, the role of the registered nurse in a variety of different job titles is so important. Most importantly, the care management role. And it's going to continue to grow and evolve. We're starting to see in many nursing programs a resurgence in the growth of care management master degree, because I think that's where people know, obviously that's where the future is going.
All right. I think that's just about time. Oh, do we have one more? I think we might have time for one more question.
We got two over there.
Students, and also, when we're on the wards, how can we help with that and stuff? How can we help?
Sure, that's great. Gosh, I love help. I think, I think clearly it's being a supportive colleague, as I mentioned. What we've tried to do is really empower particularly our novice nurses to feel they could speak up appropriately and be that advocate for the patient. Oftentimes they're with them the most. And so if they call you and say, I have a concern, most of our physicians and our medical students and our residents do listen clearly. But just to take a moment to really listen. And I think that's how you support that empowerment and that magnet culture. My advice to you is that, please always ask for help. We all need help, right? None of us know the answers. No matter how long we've been here or in our profession or in our specialty. I think that's the beauty of this organization. That's what's kept me here for so long, is really the collaboration that I've seen, the team building over the years, that we can feel comfortable with asking one another a clinical opinion or a professional opinion outside the clinical setting. And it's really, it's unique, I will have to say. It is unique. I've had the opportunity to go to different organizations and listen to different colleagues across the country. We're unique. And so whether you stay here, obviously, or go elsewhere, don't be afraid to ask questions. You're welcome.
Are we good with no more questions? All right, guys. Well, thank you. Is there?
She had one more.
Okay, last one.
Yes.
Sorry.
I was wondering what some specific strategies that were put into place here to help teams better work together and communicate.
That's a great question. So we're doing a lot of work as an organization around interprofessional education. So particularly surrounding communication and how do we communicate with one another. So we have some experts, physician colleagues, Dr. Franco helps us as well. We have some of our nursing leaders come together to see what does that curriculum look like. Starting with some of our medical students and our nursing students, how do we bring them together? I'm sure you've all been over to Health Space, right? Have you been over to Health Space at all, where the simulation is?
They haven't yet.
They haven't yet. So we have a wonderful facility across the street and one on the west side of town that really brings all of our disciplines together. And the purpose there is really to role play during clinical settings, but we videotape everybody. And then we get a chance to kind of debrief and obviously focus on the importance of the clinical decision making. But really the crux of it is how do we communicate with one another, and effective communication. So that's just one way that we try to incorporate that into the curriculum. But we know that moving forward, clearly, as I mentioned earlier, it's a team sport, and how can we both be great partners, not just nursing and physician, but our pharmacy colleagues, physical therapy, anybody who has anything to do with the care of the patient. So there are a lot of efforts in the organization surrounding that. It's a great question.
All right, so I think we're just about at time that you guys get to class. I want to give a thanks to Dr. Hancock for joining us this morning.
Honestly, it's a pleasure. And I know, you're all the best and the brightest, and I wish you the best of luck. And I know you're just going to be great and successful, and there's anything that we could ever do for you, please don't hesitate. So best of luck to all of you. And go Ole!
All right.
It's easy to see why we